The floor is yours.
Good morning, Dave. Thank you. Thank you, Susan. Thank you, Melissa, Alana, everybody that has joined the call this morning. I apologize for my tardiness. Time is not on my side this morning. Sorry about that. And so I think I'm just going to take off on this slide. Hopefully, Melissa was able to introduce a little bit about IHS. Of course, it's important to realize the legal basis for federal services. And according to all of this list of, it includes the Constitution, different legislative acts. All of these are very important when it's determined to provide healthcare to Native Americans. And let's go to the next slide. So I'm just basically going to read this word for word. You can read it for yourself because this is very important, and this comes right off of IHS.gov. The trust relationship establishes a responsibility for a variety of services and benefits to Indian people based on their status as Indians, including healthcare. Treaties between the US government and Indian tribes frequently call for the provision of medical services, the services of physicians, or the provisions of hospitals for the care of Indian people. And the US Constitution specifically addressed the federal government's primacy role in dealing with Indians in commerce and treaty clauses. Supreme Court cases such as Cherokee Nation versus Georgia back in 1831 helped create the guardian and ward relationship that forms the basis of the trust relationships. Next slide. And continued, as citizens of the United States, they are eligible to participate in all public, private, and state health programs available to the general population. In addition, they also have treaty rights to federal health care services through the Department of Health and Human Services. The federal trust responsibility to uphold the treaty responsible for healthcare is accomplished by consulting with Indian tribes and then actively advocating for policy, legislative, and budgetary planning. And next slide. Also important, we have mission, vision, and a strategic plan. The mission is to raise the physical, mental, social, and spiritual health of American Indians, Alaska Natives to the highest level. Our vision is for healthy communities and quality healthcare systems through strong partnerships and culturally responsive practices, including this coalition. Next slide. And let's see. So can you back up one slide? The strategic plan accomplishes primary things with the mission and the vision. There are 3 goals, and we'll talk about those in more detail. Next slide. Goal 1 is access. So to ensure that comprehensive, culturally appropriate, personal, and public health services are available and accessible to American Indian Alaska Native people. This is accomplished through programs such as the Purchase Referred Care, PRC, that was previously called Contract Health Services, recruitment and retention, which Susan told you a little bit about. We need to ensure access to much needed care. We have training resources and maintaining clinical proficiency of professional staff. Next slide, quality. I'm not sure how much Melissa told you. She is our area director for quality. So this is her lane for sure, to promote excellence in quality through innovation of the Indian health system in an optimally performing organization. We are striving for Joint Commission hospital and clinic accreditation, as well as PCMH certification. Melissa has undertaken governing body rehaul and reorganization throughout the area. We have severe staffing and funding shortages, that is well known. We want to align service delivery processes to improve the patient experience and ensure patient safety. We want to establish agency-wide patient wait time standards. We are working on those. and to improve processes and strengthen communication for early identification of risks and mitigation of those risks. Goal number 3 is optimize management and operations. To strengthen IHS program management and operations, we need to improve communication and collaboration across the system. So that not only includes getting on the same page within the Billings area, but also across all 12 areas of the IHS system, as well as our community partners and referral facilities. Our managers need tools and resources to make data-driven decisions. Many facilities are operating at or beyond capacity, and that was pre-pandemic. Now, during the pandemic, certainly things have changed. The average age of our IHS facilities is 36 years. We have one of the oldest operating facilities across the nation on the Wind River on the Wind River Reservation at the Fort Washakie Clinic. Information technology concerns with rising costs and increased security threats. I think that's a global goal for any healthcare organization. All right, let's see. Performance. So our performance measures are primarily provided through the Government Performance and Results Act. We call it GPRA. There are 26 metrics that we strive to reach throughout the year. It is coming up on the end of the fiscal year in about a week, and that's, I believe, when the GPRA ends as well. I'm not sure. Melissa might need to clarify that. It could be based on the calendar year, but I believe it is on the fiscal year. We also have the GPRA Modernization Act. This is tracked annually and reported in the IHS Congressional Justification and on the IHS Quality website. And of course, these measures always help with funding as determined by Congress. National Accountability Dashboard for Quality. There's data on key quality measures to ensure compliance with IHS policy requirements, accreditation standards, and/or federal regulations. This is reported quarterly and available on the IHS Quality website. So other dashboards that we currently have include metrics from the emergency department, governing body, and opioid use. Next slide is our key leaders currently in the Indian Health Service. Since the last time I gave this presentation, we have a new acting director. It is Elizabeth Fowler, and we have a new chief medical officer, Dr. Loretta Christensen. Next paragraph on the organizational structure. As anything with the federal government, there are a lot of abbreviations and well, you can see our headquarters are based in Rockville, Maryland. There's under the office of the director, there's the ODSCT, OTSG, OUIHP, and everything else. This actually, I believe, goes into the next slide, headquarters continued. You can see all the different offices that operate under the the agency director and headquarters in Rockville, Maryland. Next slide on the regional offices. Like I mentioned, there are 12 of them. Billings is our area, which comprises the tribal communities, federal facilities, and urban organizations in Montana and Wyoming. So further information about the Indian healthcare system, we have, like I mentioned, the IHS Direct Healthcare Services. Those are the federal facilities. We have the tribally operated healthcare services, Title I and Title V of the Indian Self-Determination and Education Assistance Act. And today, over 60% of the IHS appropriation is administered by the tribes. So only 40% of that appropriation comes to us federally, direct care services. And then also there's a pot of money that goes to the urban Indian healthcare organizations that was established in 1976, and currently there are 41 urban Indian organizations. There are 5 here in Montana and none currently in Wyoming. Next slide, system continued. We have IHS budget appropriations. You can see every year it has gone up a little bit. It is still extremely underfunded, but we make do with what we do get from Congress, but also from third-party sources. So just as an example, the per capita personal healthcare expenditure comparison for fiscal year 2017 in IHS, it was $4,078 per person. The US national health expenditure per person was $9,726. Next paragraph, for human resources, there are approximately 15,370 employees. You can see the number of nurses, physicians, pharmacists, dentists, physician assistants, and environmental health and sanitarians. Of course, this could change on a daily basis. Next slide, system continued. Let's see, 5 IHS and 8 tribal hospitals are critical access hospitals. There are 24 IHS hospitals, 22 tribal hospitals, and then you can see the breakdown of the health centers, health stations, Alaska Village clinics, school health centers, and youth regional treatment centers. Okay, for the Billings area, like I said, it includes Montana and Wyoming. There are over 70,000 American Indian and Alaska Native people in our area that we serve. I think with the pandemic, those numbers certainly have increased as a lot of our urban population in the much larger cities like New York, LA, San Francisco, Denver, etc. A lot of them may be moving back to be closer to home and family. Next slide shows a map of Montana and Wyoming. And I think the next slide has a better map of the reservations. And of course, our newest federally recognized tribe is Little Shell, and they're based out of Great Falls. I don't know yet for sure what their plans are as far as forming a reservation, but I know that they do own land in the Great Falls area, but their tribal members are dispersed throughout the state of Montana. We'll talk more about that in a bit. Our first service unit, and of course, this is in no particular order, but alphabetically, even though I'm a member of the Blackfeet Nation and I'm a little partial to them. This is my home. We have 2 health facilities, the Blackfeet Community Hospital, which is our only full-fledged hospital in the Billings area. And then about 30 miles south is the Heartbeat Health Station, which is ambulatory only. It serves primarily the native people of the Blackfoot Confederacy. The South Piegan or Blackfeet are the only tribe and reservation that's located in the United States. The North Piegan, Piikani, Blood, Kainai, and Blackfoot Siksika are our 3 sister tribes that are located in Canada. The only thing that separates us is the US-Canadian border, but we all share the same language and similar customs and traditions. It first opened in 1937, serves over 7,000 tribal members. An additional 7,000 tribal members live off reservation, living all over the world. The hospital in Browning is 110,000 square foot, has 28 inpatient beds, 8 bays in the emergency department. They fill about 1,200 prescriptions per day and have about 131,000 patient encounters per year. The Blackfeet Indian Reservation is large at 1.5 million acres. It's slightly larger than the state of Rhode Island, and we are adjacent to Glacier National Park. If you haven't ever been there, you need to go. It's awesome. The Museum of the Plains Indian is located in Browning, and the Blackfeet Community College is a source for higher education.
And Dr. Williamson, this is probably about 3 years ago, but I think at about one time I was told that Blackfeet Hospital was the 2nd busiest ED in Montana. I don't know if that's still
Right. I've also heard from current staff that they, by volume alone, it's about the fifth, lately that it's been about the fifth busiest emergency department in the entire state. So they see a lot of people there. Next is our relatives just southeast of here on the Crow Reservation. They operate the Crow Northern Cheyenne Hospital, the Lodge Grass Health Clinic, and the Pryor Health Station. There are over 200 employees for a 24-bed health facility. It is a critical access hospital. And their reservation is even bigger than the Blackfeet at 2.2 million acres. They have the Little Bighorn Battlefield Monument, as well as, you know, the Yellowtail Reservoir and all the wonderful outdoor opportunities that that has. According to the great Crow leader, Arapuish, I'm not sure if I pronounced that correctly. I had to ask our friend Leanne Brucehead, and I knew I was just going to mess it all up. So I'm sorry about that. But Crow country is good country, great spirit, put it in exactly the right place. And I love that saying. Next up is Fort Belknap. The Fort Belknap Hospital, located near Harlem, is also a critical access hospital. And in Hayes, there's the Eagle Child Health Station. That facility services two tribes, the Grovon and Assiniboine Nakota Sioux. 6 beds, over 50,000 outpatient visits per year. There are about 6,000 members that live on the reservation, and according to their records, there's about 1,500 members that live off. Exciting things about the Fort Belknap reservations include Snake Butte, the Chief Joseph Battleground Monument, C.M. Russell National Wildlife Refuge, and the Fort Belknap Community College. And so it's really exciting for me to learn more about our facilities, because having grown up in Browning and the surrounding area, I always thought everything east of Great Falls was flat and grassy, and coming into this position and traveling a lot more through our facilities, every reservation is beautiful in my eyes, and they're very unique. And so this is a little bit of a recruitment tool, of course, for our facilities. Next is Fort Peck. We have 2 ambulatory clinics there. The Chief Redstone Clinic is located in Wolf Point, and east of there is the Vern E. Gibbs Clinic in Poplar. And Poplar is kind of considered to be the main headquarters for the Fort Peck service unit. There are 2 nations there, the Sioux, Sisseton, Wahpetons, the Yanktonai, I'm not sure if I'm pronouncing that correctly, and the Teton Hunkpapa, Assiniboine. And these are bands of the Canoe Paddler and Red Bottom chiefs, I believe. The user population is over 8,000, and their reservation is just over 2 million acres. Located there, we have the Fort Peck Community College, the Fort Peck Reservoir, and again, a lot of outdoor opportunities on the Missouri River. Our newest service unit is the Little Shell. It is the ambulatory clinic located in Great Falls, Montana. I know it says the opening is October 1st. We are not quite ready to achieve that goal, so that has been postponed a little bit. So watch for that. They are the 574th federally recognized tribe on December 20th of 2019. This is the Little Shell Band of Chippewa Indians of the Ojibwe. There are over, 5,400 members located throughout Montana and across the US. And again, the tribal headquarters are located in Great Falls. Next paragraph, for Northern Cheyenne, our probably next closest neighbor after the Crow. They are also an ambulatory clinic with outpatient and a 24-hour urgent care department that services 6,300 enrolled members. An exciting thing about their facility is that they do use a healing room for traditional ceremonies. They are accredited by IHHS with medical home accreditation, but as I mentioned earlier, we are moving all of our facilities towards Joint Commission, and so that will be changing. The reservation is a little bit smaller at 444,000 acres, and there are over 11,000 enrolled members totally. Exciting things there, Custer National Forest, Chief Two Moons Monument, and Chief Dolnav Community College. We see a lot of powwows, rodeos, fairs, and athletic events on the Northern Cheyenne Reservation, but also on all of our reservations. Next service unit is the Wind River. They are our only service unit in Wyoming. They service 2 tribes. The Eastern Shoshone at Fort Washakie Health Center is IHHS, and the Northern Arapaho with the Wind River Family and Community Health Care is a tribally run facility. They also have a 2.2 million acre reservation and over 14,000 user population. Again, they are also AAA-HC accredited and will be moving to Joint Commission. A lot of exciting things around their reservation include the Wind River Mountain Range, Yellowstone Park, Thermopolis Hot Springs, South Pass City, and the Central Wyoming College in Riverton. So we have 2, next slide shows that we have 2 tribally operated health departments, one on the Rocky Boy Reservation and one on the Flathead Reservation. I'll talk a little bit more about those. But of course, I need to explain tribal self-governance. Under the authority of ISDEA, Title I and Title V tribes can assume responsibility for healthcare formerly offered by the federal government. The tribes may contract with IHS through self-determination contracts and annual funding agreements under Title I, or complete self-governance compacts and funding agreements under Title V. So all of our tribes do a little bit of Title I, and we have 2 tribes that are complete Title V. That is the Rocky Boy and Flathead. So that affords the tribes the most of flexibility to tailor healthcare services to the needs of their communities. First, we'll talk about Flathead Tribal Health. They are headquartered in St. Ignatius. They were actually a self-governance demonstration program that began in 1988 and became fully in 1993. So I don't think they have ever been operated as a federal facility. They serve 3 tribes, the Bitter Salish, Upper Pend Oreille, and Kootenai. Reservation is 1.3 million acres and serves over 12,000 members. They only have health centers as there are privately owned hospitals located on their reservation. I believe the main one is in the main one that they utilize is in Polson. But you can see they have health centers in Hot Springs, Elmo, Polish, Polson, Pablo, Ronan, St. Ignatius, and Arlee. And of course, if anybody's been to the Flathead Reservation, it is one of the most beautiful areas with Flathead Lake, the Mission Mountain Wilderness Area, the National Bison Range at Moise, and the Nine Pipe National Wildlife Refuge. Rocky Boy Tribal Health serves the Chippewa Cree tribe. And an interesting fact is that the Chippewa chief Rocky Boy nor the Cree chief Little Bear ever signed treaties for land. So their reservation was created by a congressional act on September 7, 1916, and the Rocky Boy Health Board formed and was incorporated in 1974. They serve about 7,000 enrolled members, and just over half also live on their reservation. Locally, we have the Stone Child Community College, the Bear Paw Mountains, and Beaver Creek Park, which was a gift to the city of Havre. It is considered to be the largest county park in the United States. So moving on to our urban programs, a little bit of their history. In 1950s, 1960s, there was the relocation efforts to move natives off reservations for assimilation into the larger cities and into mainstream society, primarily San Francisco, Los Angeles, Chicago, Salt Lake, and Phoenix. Over 160,000 American Indian Alaska Natives were relocated during these efforts. In the late 1960s, the urban Indian community leaders began advocating for healthcare, and a pilot clinic was formed in Rapid City in 1966, and then followed by a health study for urban Indians in Minneapolis in 1973. Congressional appropriations soon followed according to the Snyder Act. And then in 1976, the Indian Health Care Improvement Act created our urban programs. And so in the Billings area, we have 5 urban Indian health programs. In Billings, we have the Urban Indian Health and Wellness Center, the Indian Family Health Clinic in Great Falls, the Helena Indian Alliance and the Leo Pocha Memorial Clinic in Helena, the North American Indian Alliance in Butte, and the, let's see, in Missoula, they changed their name to All Indian Health Center, I believe. Does anybody know? All Nation.
Yep.
Thank you. All right, so I don't have a lot of information about the urban organizations because they're kind of run on their own. And so I'm going to the next slide, and under program examples, you know, with our partners, Montana Healthcare Foundation, the National Native Children's Trauma Center, Mountain Pacific Healthcare, we implemented a trauma-informed care program in all of our 12 organizations, and the name was changed to Heal, Rise, Live, Repeat. That was extremely active. Thank you to Alana and everybody else that was so instrumental in getting that involved. You know, with the pandemic, it's kind of changed priorities a little bit. And so even though trauma-informed care has moved a little bit to one of the back burners, it is still a very important program for our facilities. And of course, it involves organizational and clinical practices in making widespread changes to address trauma and its impact on our population. Next slide. This is our Heal, Rise, Live, Repeat, also known as trauma-informed care program. You can read those. But the important thing is that Indian cultural healing methods are accepted and encouraged as tools to building resiliency and recovering from trauma. Here's the next slide shows a roadmap to trauma-informed care. How do we get there? I'm not going to go through all that. It's quite busy, and it's primarily just in the interest of time. So next couple slides show the effects of historical trauma, or not really the effects, but also the things that led to historical trauma. And this I gathered from a Blackfeet tribal elder. It all started before 1492 in the Columbian period, moved on to the colonial period in the mid-1800s. We had the removal, reservation, and treaty period. Following that, it was considered the allotment period, Indian reorganization period, the termination period, and the self-determination period followed that. And from 2000 present, we are in the nation rebuilding period. And a couple things that happened specific to the Blackfeet tribe, the smallpox epidemics occurred in 1780 and 1837. The Baker Massacre occurred in 1870, starvation winter of 1883. Boarding schools began in 1884. We had the TB epidemic in the 1940s, the polio epidemic in 1958. And then in 1964, an example of a natural disaster was the flooding that resulted in 2 dams failing and several people losing their lives, their homes, and everything. And so all of these things that occur historically become a part of our genetic makeup, and that's how it affects us to this day. So next slide, I'm going to change topics, change gears here a little bit to the Community Health Aid Program. It was first initiated in Alaska in 1968. It is a proven strategy for increasing access to much needed health services and improving the quality of those services in Indian country, as well as other rural and frontier areas. So Under the Fort Belknap Indian Community Leadership, the Montana Chat Program in House Bill 599 was signed into law by Governor Bullock on May 9th, 2019, as an effort to increase the healthcare access in our communities here in Montana. Includes the community health aides, behavioral health aides, and dental health aides. Therapists. The community health aides are primarily first responders, and we're still working on going to the next slide. Community health aide, they assist with acute preventive primary care services as appropriate to the individual certification. In Alaska, they're primarily first responders. And since we already have fairly developed EMS systems here in Montana and Wyoming, we're still trying to figure out how to best utilize the community health aides in conjunction with the longstanding program, the community health representatives. And so we got to work with those two entities. The behavioral health aides, they assist with case management, patient and community education, and patient evaluation, treatment planning, and treatment activities as appropriate to the individual certification. A behavioral health practitioner may, only under the general supervision of a licensed behavioral health professional, conduct routine screening, assessment, evaluation, and counseling of patients. And so there's various levels of community health aide, behavioral health aide, and dental health aide. Next slide. The dental health aides assist with dental education and primary or preventive dental care as appropriate to the individual certification as well. Okay, so the next slide under successes for the Indian Health Service. We know that this is a successful model for Indigenous health programs with its respect for cultural beliefs, its blending of traditional practices with a modern medical model, and its emphasis on public health and community outreach activities. We frequently have federal consultation with tribal governments on how to improve the delivery of healthcare, et cetera, facilitation and involvement in policy development, setting program and budget priorities, and continuously advocating for health needs. Continued successes include life expectancy that has increased by about 10 years since 1973, and mortality rates have decreased for all of these significant health issues: maternal deaths, tuberculosis, gastrointestinal disease, infant deaths, unintentional injuries and accidents, pneumonia, influenza, homicide, alcoholism, and suicide. On the next slide, some challenges of the Indian Health Service. Indian people continue to experience health disparities. The life expectancy is still 4.4 years less than that for the US general population, and mortality rates are still significantly higher for those illnesses and disease processes. So health status is not just a healthcare issue. It involves adequate economic, employment, education opportunities, and safe communities with suitable housing. And it is vital that all available resources, federal and private sector, be brought to bear on all Indian health issues. And so that is the end of this presentation. If there are any questions, there's my email and phone number for to contact me. I am also very happy to see that several of my colleagues are here, and so I encourage them to speak up, because I'm sure that there are a lot of questions, as I'm fairly new to the Indian Health Service system, that I might not know, and I'm glad to have them here to help me. Thank you very much.
Yes, thank you, Dr. Williamson. You did a wonderful job.
Thank you.
Yeah. So if you do have questions for Dr. Williamson or any of the IHS folks on the call, you can just unmute yourself, or you can put that in chat too.
I know it's a lot of information, and let's see. Dr. Temporal, eligibility for services determination. So that is determined on a case-by-case basis through the purchase referred care personnel. They have to follow a lot of rules and regulations. It really depends on your enrollment, where you live, etc. But we work really hard to provide care to as much people as possible with our referral system.
So just to follow up on that, the question came up yesterday. So do you qualify for services at an IHS facility because of geography, or is it strictly by association?
So anybody actually can get services at an Indian Health Service facility. The main distinction is between beneficiaries and non-beneficiaries, and largely beneficiaries are going to be Native American, American Indian, Alaska Native people. So even though I'm Blackfeet, I can go to the Crow Northern Cheyenne Hospital, be registered as a patient and receive direct services there. If, say, for example, there was a non-Native person that hurt their leg at visiting the powwow or something, they are more than welcome to be seen at the emergency department there, but then would have to be referred elsewhere for further treatment. So in emergency cases, we can see non-bens.
This is Susan, and I'd like to add one other point to that. And the other way that a non-Native person can receive care through our facilities is a woman carrying a Native child can receive prenatal care and postnatal care, throughout that pregnancy. So that is one other way that a non-Native can receive care through any of our facilities.
That's correct. And I also believe our First Nations relatives in Canada can also receive care as well.
In terms of purchase referred care and I'm just speaking, I used to work in IHS in North Dakota. Historically, it's been where if they are living off the reservation and they want to use, let's say they go to Billings Clinic, they would have to be referred from the IHS facility because they couldn't just schedule an appointment at Billings Clinic on their own and then just have IHS pay for that. Is that still correct?
That's correct. If, like, for example, I'm living off reservation, but I also have private healthcare insurance. And so I don't have to go to an IHS facility to get a referral. I just utilize my private insurance and go directly to Billings Clinic, St. Vincent, wherever I need to. So that's another option too. And a lot of the tribes are also forming these health insurance programs as well, so that their members can do that for themselves, but they can also, it's another a source of revenue for the local facilities too, by having private insurance. It's complicated, and like I said, I'm still fairly new to the Indian Health Service, and I'm still learning quite a bit about the PRC program. I don't know if that answered your question or not, Dr. Temporal. We can certainly discuss more offline if you'd like.
No, thank you. That was helpful. If I could ask another question, your historical slide had mentioned at the end that from 2000 on, we're in a period of tribal restoration or something. I forget what the word was. And could you explain more of what I don't know if there's a goal or what the philosophy is of this current period of what restoration means and what, they hope to accomplish?
So I think, and this is just a personal point of view for me, and my experience growing up on the reservation, when people were taken off the reservation, when boarding schools became present when missionary schools became present. When they took those young children, they tried to assimilate them into non-native ways of life. So they weren't allowed to use their language. They had to cut their hair. They had to change the clothes that they wore. And so that created, it had a ripple effect across many generations. And so now, it's not, there's always been these efforts to retain the language, the culture, the traditions. But now it's even more important to do so because, none of our tribes have strict laws about marrying members of the same tribe. And so what you end up seeing is tribal members from different tribes mingling, marrying, having offspring. And so if you have a child that's of maybe like Blackfeet and Crow descent, like how do they learn both languages, both traditions, both cultures? And so, the tribes, I think, encourage family members to carry on the language, the traditions, etc. I know at Blackfeet there is a language immersion school, and so once you get on their campus, everything is taught through the Blackfeet language. Math, science, all of that stuff is taught from the Blackfeet language perspective. And so it's very complex, and it can be difficult to understand because I think a lot of people have different experiences and perspectives. And so I think if you're talking about, like, if it comes up in a patient encounter, I think it's very important to listen to what that patient has to say, because their experience is going to be different from mine. And then just realize that there's a lot of that historical related changes and trauma, et cetera, that plays a role in the current day lives, our current day lives. I don't know if anybody else has anything to add to that. I see a question. Oh, go ahead, Susan.
I was going to say, this is Susan, and the only thing I'd add to that to help with the understanding is that you need to understand that a lot of those things are passed down, and that trauma is carried through because of the multi-generational living. In one household, you'll find great grandparents, grandparents, and the information that Dave sent out, it clearly demonstrated that grandparents raise grandchildren. So a lot of those traumas have been passed down through that avenue. So I just want to make sure that you understood that multi-generational factor in living.
That's correct. And I see there was a question from Roxanne in the chat. Has there been any discussion for hospice care reimbursement? I haven't been involved in any discussion specifically related to that. I wish one of our purchase referred care staff members were on, but I can certainly find out. And I can send a response to Dave, and then he can distribute that. I'm pretty sure that I know personally that hospice care does occur on the reservations. I just don't know about how it's covered if a member is off the reservation. And I don't know if any of our other staff members have anything to add for the hospice care reimbursement. So we'll look into that for you.
My sister is a public health nurse in North Dakota up at the Turtle Mountain Reservation, which is the reservation I'm from. And I do know that public health nurses will go out and do that, and that's covered under IHS. But in terms of billable services, I know it's a little bit tricky when it comes to specific hospice care, just because, you know, if there's IV pumps and things like that, that is not under the scope of services that public health nurses, I think, are, you know, quote, allowed to do. So it's a little bit limited when you're on, but yeah, I think that off the reservation, that the you know, third party billing would need to come into place, I think. But
Yeah, and I've also heard from personal experience that a patient's hospice care was fully reimbursed by a tribal health department, even though that patient was not a member of that tribe. They had worked for a long time for that tribe. And so the tribe just felt like it was their duty to help alleviate the patient's suffering. And so they completely paid for all of the patient's hospice care. And I just thought that was such a neat and wonderful gesture. So it does happen. I think it has to be determined on a case-by-case basis, because I think the events surrounding both the beginning of life and the end of life are very important across our Native communities and culture, that we definitely want to take care of those aspects of our lives. Okay.
well, you're getting lots of accolades, Dr. Williams, and everybody is very appreciative of the information.
I'm so sorry if there are for being tardy again. If anybody has anything more specific that you would like to hear about IHS, certainly I think the purchase referred care department is an important one that we could present at this coalition. If there are any other departments that you'd like to hear more information about, we can get that arranged.
Wonderful. Yeah, I think that would be super helpful. Roxanne says Riverstone Hospice provides care to Native American primarily without reimbursement. There have been few situations with reimbursement. Thank you for all this information. So, good to know.
Thank you, Roxanne. And I will definitely look more into that, okay? We appreciate all the help that Riverstone gives to our community members.
Yes. Well, thank you very much, everybody. I appreciate you joining and listening in. And if you do have any questions or anything like that after the presentation today, you can see Dr. Williamson's email right there, or you can get a hold of myself, Aide at mpqhf.org. So you all have a great rest of your day.
Thank you all. Take care.